Thank you. This section is going to focus on the multidisciplinary assessment of patients with EGPA. So, I discussed in the previous section the wide range of organs involved and the concept of waves of inflammatory activity that patients have, and then the progressive accrual of damage, running in parallel with inflammation caused by EGPA are comorbidities that patients with EGPA are susceptible to. And these typically parallel, or the risk of these comorbidities parallels high disease activity and high steroid doses. So I'm considering here infections, cardiovascular events such as myocardial infarction and stroke, and thromboembolic disease, such as deep venous thrombosis and pulmonary emboli. They're the three most common categories of comorbidity. Focusing in on high disease activity, we know that if the eosinophil count is particularly high, that patients are more at risk of having vasculitic events, such as central nervous system lesions or vasculitic events elsewhere. And we know that the high level of eosinophilia and eosinophil infiltration is involved in injury to myocytes in the heart with direct toxic damage by degranulation of eosinophils. In terms of treatment, EGPA is a steroid-responsive disease, but it requires reasonably high doses of steroids. And compared to other vasculitides, immunosuppressants such as cyclophosphamide, azathioprine, or mycophenolate are slightly less effective at being steroid-sparing agents. As a result of this, EGPA patients suffer a high burden of steroid-related toxicity, both in terms of short-term toxicity, but also long-term adverse events. And here I'm talking particularly about metabolic events, diabetes, hypertension, weight gain, bones, cataracts, and so on and so forth. And of course, the more aggressive the disease, the higher the steroids that are likely to be used. But then the more refractory or relapsing the disease course, the greater the cumulative burden of steroid over time. So those patients who present with poor disease prognosis, namely cardiac, renal, gut, or CNS disease, have a high mortality, and this justifies a high level of steroids to try and get the initial disease control. These patients will also have higher healthcare utilization. They're more likely to require specific input in terms of the organs involved, and certainly the developing capacity that is going to require much more long-term care. Comorbidities and serious relapse of disease and serious adverse events are the major drivers of cost after the initial diagnosis and treatment of this disease. So we've talked already about the range of organ manifestations and the need for specialists in each of the disease areas is both to accurately assess that the symptoms in that disease are being caused by EGPA rather than another cause, but over time also to support the treating physician with their assessment as to whether the disease in that particular organ is active or not. In other words, if it's active, we should increase treatment. If the disease is not active, then we can potentially reduce treatment. The specialists have a further role in advising on the management of damage in those particular organs. For example, an ear, nose, and throat specialist can advise in the management of hearing loss. The table here simply summarizes the proportions of patients with EGPA and the diversity of specialists that are required. So overlaid on the table is a list of specialists. And one of the subtexts to this, because EGPA is a rare disease, the individual specialists will see even fewer patients than the physician running the EGPA clinic. And this puts a premium on trying to collate EGPA patients into a relatively small number of larger clinics, because then the individual organ specialists supporting the EGPA service will develop more experience of the varying EGPA manifestations. It's also important to say that this list is not exhaustive. And for example, EGPA patients become pregnant, and then you're talking to maternal-fetal medicine doctors or obstetricians about them. So pretty well any part of the hospital can be involved with an EGPA patient.
David, thank you very much. It's very clear from the presentations we have about the protein manifestations and how it may present to a range of specialists. So you've emphasized the importance of a multidisciplinary approach. Perhaps we might benefit from hearing how you feel best practice is from that point of view.
So I think the best practice is that EGPA patients are collected under one clinic, or as much as that is practical. But it doesn't actually matter from my perspective the specialty background of whoever runs that clinic, provided they have access to the specialists that they need to support their patients. So I think collating patients in one place and then building out support structures such as specialist nurses who can help supervise the medication that you're offering, and also counsel patients through their collective experience of working with other EGPA patients is important. The other issue that we have in dealing with a rare disease is that we sit in our large academic hospitals, and the patients we advise come from quite a distributed geography. And so I think another important part of the care is how we link in with local physicians, how we support them as far as possible, ensuring high quality care without necessarily the patient always having to come, especially in these times of the COVID pandemic, having to come to the centre. And certainly within the east of England where I work, we tried to develop this sort of hub and spoke approach. This also has the benefit of discussing referral thresholds and diagnostic pathways with one's colleagues in other hospitals in the attempt to get patients picked up early and then referred through early.
No, certainly, I suppose that approach with a hub and spoke allows sort of bi-directional communication and education as well. So standards will improve within the framework of that. Is there any tips about shared care?
So I think that the key thing is to we think registries are very important to catalogue what you're doing, but registries I think are also an important tool for quality control. So you can assess serious adverse event rates, you can assess relapse rates. If you've got a registry, you know what your patient population is. And we build in the education into our regional respiratory, rheumatology, and nephrology courses so that it's part of the sort of more general specialist training that physicians are receiving. But I think we've probably been slow in terms of direct patient education, and I think there is certainly room to improve there. And working, with other specialists who maybe have taken these diseases, have been involved in patient education for a bit longer, I see the benefits of patients actually going on to almost formal courses about their disease, about their treatment, about how to manage complications, about when they need to contact health professionals and so on. It's all part of quality chronic disease management, and I think that should be a focus for us.
No, I think there's some very helpful guidance there. Thank you very much.